Hello, everyone, and thank you for tuning in. In this episode, Dr. James Del Rosso will share some highlights and clinical pearls regarding top acne treatments. Thank you so much for being with us today, Dr. Del Rosso.
It's a pleasure to be here.
What is your personal approach for exploring alternative treatments for acne patients beyond first-line therapies?
Well, when we see an acne patient, we obviously judge based on a lot of factors of what's going on with that patient. What we see is the severity on that day, what we hear from them as how severe their acne might get at times, how it bothers them, treatments they've used, and to some extent, the age of the patient, and also factors in terms of what they're most likely to comply with or adhere with the regimen. So I'll choose an initial therapy, which is usually going to be a combination of topical products or possibly a topical regimen with an oral agent like an oral antibiotic. And then I have to judge generally about 6 to 8 weeks later how that patient's doing. And that can include not only if they're having any adverse effects or problems with using the medication, but their response. And we don't certainly expect them to be completely clear at that time, but we recognize that they should be improved and they should have fewer and fewer new lesions coming in as time goes on. That's generally going to take about 6 to 8 weeks. It may be faster, but that's usually the time frame. So I'll generally see them at that point. If I don't see any change, then I'm inquiring about whether they're actually using it and talk to them eye to eye, not to create any judgment, but tell them, hey, I'm human. Just like you, when I was your age or I had acne, I missed applications too. So tell me what you're actually doing. If they are, I have a sense that they're compliant with their treatment, then I might make an adjustment that early. But I typically try to get them out to 10, 12 weeks before I'm making major adjustments if I can. But realize if they're really not getting anywhere by 6 to 8 weeks, there's a problem, and I might need to adjust then with some other therapies. What I choose is going to depend on the clinical situation.
Dr. Del Rosso, can you compare the emerging topical treatments for acne?
Well, these newer therapies that have become available for the topical treatment of acne, I'll break down into two categories. There are chemical compounds that have been around for many years, like tretinoin and tazarotene, both of which are retinoids. And they're in newer formulations. So there is a polymeric emulsion formulation, which uses a honeycomb mesh, which is really basically an inert mesh where they partition the active ingredient in different components of the vehicle that are usually moisturizing and lend to greater penetration of the active ingredient with improved tolerability. So there is a tretinoin lotion, Altrino, and there's a tazarotene lotion, Eraslo, that uses this technology. And the efficacy has been very favorable, and the tolerability also very favorable, especially with the tazarotene because it's 0.045%, which is less than half of the 1% tazarotene that we typically use. On the other side of the fence, we have new compounds. We have a new topical retinoid, trifarotene, which is a retinoic receptor gamma specific retinoid. Whether that makes any clinical difference, we don't know, but it might. But all the retinoids affect retinoic acid receptor gamma, RAR gamma, which is the major receptor in the skin. They all do. But trifarotene is more specific. It's also the first agent used for the treatment of acne that was formally studied in phase 3 trials for truncal acne. It actually evaluated utilizing global assessments and lesion counts of truncal acne, and it's approved for both with specific large-scale studies for the face and the trunk. There's also topical clascoterone, which is androgen receptor inhibitor. It's the first androgen receptor inhibitor that we have that is FDA approved. It's available topically. We've been using spironolactone and even combination oral contraceptives to reduce androgen effects in acne, especially in women. But topical clascoterone does it without any significant systemic absorption, so we're not concerned about those side effects. It does it topically, so it actually reduces sebaceous gland ability to produce cytokines and sebum. The first time we've had that in acne, and we have it with a topical. Being topical, it can be used in both males and females. So there's no distinction there. Where spironolactone and oral contraceptives, we've only been able to use in females. It can be adolescents, but usually women past their teenage years. So that's a major advance with twice daily application, and it's a unique mode of action. We also have an oral antibiotics, sarecycline, which is a tetracycline derivative, but it's a narrow spectrum tetracycline. Unlike tetracycline itself, doxycycline and minocycline, it has a narrow spectrum of antibiotic activity, active against the Cutibacterium acnes, the C. acnes, which we used to call Propionibacterium acnes or P. acnes. That proliferates, especially pro-inflammatory strains in acne, and it reduces those. And it's been actually shown to have favorable, lesser chance of getting resistance to several of the bacteria. That was added to the package insert. So that may circumvent some of the bacterial resistance. And certainly with gram-negatives organisms where it's not very active, and some anaerobes, it has very limited activity. So it seems to spare antibiotic resistance in the GI tract microbiome, which has relevance, which is different than the other tetracyclines. And that's available once a day with weight-based dosing, with or without food. It also has a low potential for side effects that we typically think about with some of the other tetracyclines, like photosensitivity, vaginal yeast infections, vertigo, etc. It had very low incidence of those. So there are some advantages, at least based on the data that we have with sarecycline.
What are some advantages with the newer topical retinoids?
Well, with the newer topical retinoids that we have some formulation differences with tretinoin and with tazarotene, with the lotion, with the polymeric emulsion vehicle, which really improves the tolerability. The tolerability is very favorable, but the efficacy is also sustained when you look at it, both of those formulations, once daily formulations, compared to some of the pre-existing tretinoins that we've had and tazarotene 0.1% cream. The efficacy is the same, maybe a little bit better in some of the studies. Also, I know with the tretinoin and also with the tazarotene lotions, they've been looked at in a variety of different populations, different skin types and skin colors, age groups, etc., males and females, both genders. So I think that's favorable. And then we have topical trifarotene, which is a retinoic acid receptor gamma specific retinoid, and that may make a difference. We don't know if clinically that does, but we know retinoic acid receptor gamma is the one that we want to target. And it has been formally studied in the face and the trunk. It's the first agent that we have approved for acne that's formally approved for the face and trunk, based on specific trials looking at both those anatomic locations with moderate to severe acne. So I think those are differentiating factors. The other retinoids we have, obviously they work and they've been around a long time. So if we can get a patient to use a topical retinoid in a good formulation regularly, they're likely going to see improvement.
And final question, how do these new acne treatments address the issue of antibiotic resistance?
Well, when we look at some of the agents we have, and antibiotic resistance is a concern, we've been talking about it for a long time. We certainly use antibiotics, both topical and oral, for the treatment of acne. We don't want to use them as monotherapy because you're more likely going to run into resistance. When we use agents on the face, let's say a topical antibiotic on the face, we like benzoyl peroxide to be there also because it reduces any pre-existing antibiotic resistant organisms like Cutibacterium acnes and also others. And if they're going to emerge because now the patient's using a topical antibiotic, benzoyl peroxide will suppress that. And we do have in development, though it's not yet approved, a microencapsulated benzoyl peroxide, which actually appears to improve the tolerability and is an advancement in how we deliver benzoyl peroxide to the skin. We also have other good formulations of benzoyl peroxide, including an over-the-counter benzoyl peroxide agent of 5.5%. That has been shown to be as effective as benzoyl peroxide clindamycin in clinical studies. So we have some options there for trying to suppress antibiotic resistance when we're using antibiotics to treat acne. Also, we have to consider on the trunk that if we just have the patient use one of the available cleansers, even some of the better formulated ones that used to be prescription, that just washing the trunk with the benzoyl peroxide does not reduce the pro-inflammatory strains or reduce the C. acnes organism. You need to use a high concentration, and what's been studied is a 9.8% emollient foam of benzoyl peroxide left onto the moistened skin on the trunk. You make sure it's a little bit moist for 2-3 minutes, if you can 5 minutes, and then shower it off. You actually do get reduction. Within 3 weeks, you'll get reduction of C. acnes. That would be the same as using a leave-on benzoyl peroxide at 1 week. So the trunk is different. It requires more contact time and a higher concentration of benzoyl peroxide. Also, with the newer retinoids that we have, retinoids do not create antibiotic resistance. And if we have the patient using an effective retinoid and they're consistent, they may be able to circumvent antibiotic use, especially on a long-term basis. We may be able to get them off of the antibiotic. Also, oral sarecycline has a more narrow spectrum of antibiotic activity and appears that it's going to produce less antibiotic resistance. So when we look at the overall, what Jim Layden has called ecologic mischief, when patients are using an antibiotic, it doesn't only find the C. acnes, all the bacteria that are being exposed can also develop resistance. So we like having a narrow spectrum. I also want to mention that we have an advance with oral isotretinoin, and it's important to think of this as an advance. We have isotretinoins that are Lidose technology, where the isotretinoin, which was originally the brand name Accutane, that a lot of people are familiar with it based on that. That drug, the conventional formulations that we have, the branded generics, require a high-fat meal for optimal absorption. So the patient in the studies, they'd have to take 50 grams of fat. And if they were taking it twice a day, that's 100 grams of fat in the diet to get optimal absorption. If they're only taking it with water or without fat, they're absorbing 60% less than what you think they're getting. And what that translates to is higher relapse rates. You might get them clear, but they're going to more likely relapse. We have formulations that are pre-solubilized in fat, so you don't need to be concerned about them taking the isotretinoin with a meal, especially with fat. And we have advances. We have a low dose of pre-solubilized in fat isotretinoin, which I think is a major advance because you don't even have to worry about what they're eating. And there's a lot of people that are not eating a lot of fat, and they don't want you. If I came in, if you brought your teenager in and I said, have them eat 50 grams of fat twice a day for the 5 months that they're taking this, or 6 months, you're going to look at me like, this guy's nuts, because who's going to be ingesting that much fat? So that's also a major advance with these. They're branded isotretinoins that you don't have to be concerned about taking them with a meal, especially a high-fat meal. So that if the patient's going on that and they're getting that benefit over time, if you get the acne under control and you reduce the relapse, they're not going to need to be using other treatments like antibiotics. So you're also circumventing antibiotic resistance with those therapies, especially when you get the long-term benefit.
Thank you so much, Dr. Del Rosso, for sharing your insight with us today. We appreciate you and your time.
Well, it's always great to be part of this meeting. I've been a part of it for years, and I've always been honored to be a part of it. Do a great job of covering a lot of areas of dermatology, medical dermatology, cosmetic dermatology, surgical dermatology, issues we face in real world practice. So thank you for inviting me and asking me to participate in this today.
Thank you. And thank you to all of our listeners. Until next time.